think we'll get started and let people continue to join as we do introductions. Hello, everyone, and welcome to this Thematic Evaluation Study webinar on pandemic preparedness capacities in humanitarian settings. My name is Marietta Valle, and I'm the team leader for this series of evaluations for USAID's Bureau for Humanitarian Assistance, BHA, and I'm with Tango International. Right off, I'm going to hand it over to Senior M&E Advisor with BHA, Nancy Peak, to launch us with a few words of introduction. Over to you, Nancy.
Thanks, Marietta. As mentioned, I'm Nancy Peak, the Senior M&E Advisor with BHA. And on behalf of BHA, I've had the privilege of managing the performance and thematic evaluations of BHA's COVID-19 response. It goes without saying that the COVID-19 pandemic was a crisis unlike any other, and BHA's COVID-19 response touched on all countries and sectors of BHA programming. And looking back, fortunately, at the time, in the midst of professional and not to mention the personal chaos that the pandemic brought upon us, USAID and BHA had the foresight to recognize the importance of generating key from this response. So BHA commissioned early on an extensive multi-year effort, investing in a number of evaluation and learning products so we could learn from the unprecedented global crisis. So aside from traditional performance evaluations where we've assessed the results and impact of the COVID-19 funded awards, we at BHA also wanted to take a focused, in-depth look into certain technical or sectoral aspects across the entirety of our COVID-19 response, and from have two thematic evaluations. So hopefully some of you were able to join us yesterday in our webinar where we talked about the lessons learned from BHA surge funding over the course of the pandemic. And today I'm particularly excited for us to share the findings from the thematic evaluation on pandemic preparedness capacities in fragile contexts. I know you may hear the words COVID-19 or fiscal year 2020 and think, that was such a long time ago. I don't really remember. I've moved on. What does this have to do with what I'm doing now? And while I definitely can understand that in the fast-paced work that we do, in the subsequent years since the height of the pandemic, it's really become clear to me and hopefully to you as well that the lessons learned from the COVID-19 response will continue to be relevant and enlightening for the humanitarian community for years to come, especially obviously related to pandemic or public health related crises, such as the topic of this webinar. But this learning definitely goes beyond outbreak response. And unfortunately, as we see large scale shocks of all kinds that seem to be increasing in frequency, severity, and complexity, this learning really, I think, has a wide reach for us all. So lastly, I just want to say thank you to the evaluation team for your thorough and tireless work over the last few years. This report is just one of several coming out of the evaluation effort. So I encourage you to check out the performance evaluation briefs and other reports, and links will be shared with you in the chat. So thank you for joining us today. Looking forward to a presentation and importantly, hearing your comments and questions. So now back to you, Marietta.
Thanks so much, Nancy. And feel free to introduce yourself in the chat comment function if you feel comfortable. And now I'll introduce more of the team. Next slide, please. So the main authors of this thematic study were Aaron Franklin and Dr. Nancy Mock with the Celia Scott Weatherhead School of Public Health and Tropical Medicine of Tulane University, and also co-advisors and co-leaders, Dr. Shalene Collins with Tulane and Tim Frankenberger with Tango International, among many, many other team members who supported some way on the research, the data collection, the case studies from Tango and Tulane to make this study and our whole evaluation series possible. So thank you to all those team members and consultants around the world. Also, a big thanks to USAID's ITR division and a laser pulse in Purdue University, who are served as the funding mechanism for these evaluations and for hosting. Also, just some instructions in terms of Q&A. We would like to try to collect those questions you have, even that pop in your head, even during the webinar. So there is a Q&A function in Zoom for that if you can use that. Otherwise, if you're having trouble, just put those in the chat and we'll make sure to try to respond to those at the end. So with that, I'm hoping I didn't forget to thank anybody, but our gratitude extends to everyone and many of you on the call who took time to give inputs directly for this evaluation and to the series. So thank you. Next slide. So I'll present for about 30 minutes, leaving time for a Q&A at the end. First, I'll provide background and overview of the methods for this thematic evaluation, present key findings, and then conclusions and recommendations for BHA and humanitarian partners. Next slide. We were commissioned by BHA as external evaluators to conduct in-depth thematic analyses into specific aspects of BHA's fiscal year 2020 through 2022 COVID-19 response, with particular focus on topics for improved future management of large-scale infectious disease outbreaks and our global emergencies. This is, as Nancy Peek has said, one of 2 thematic evaluation studies being released this week. This one called Thematic 1 and Thematic 2, which discuss lessons on BHA's surge funding, including benefits and indirect consequences of surge funding for BHA, partners, and communities, was released with a webinar yesterday. And we'll provide links for that either in the chat and at the end, you'll be able to find the resources for that study. Next slide. When this evaluation team launched the performance and thematic evaluations 2 years ago, it included an extensive inception phase with scoping interviews with BHA and a scoping e-survey with partners. The topic of readiness and preparedness for future global health threats building from the COVID-19 responses in humanitarian settings began to emerge. The FY21 COVID supplemental through BHA included a funding objective to improve and strengthen the humanitarian architecture to support scale-up of infectious disease response capacities. And this was a new focus in FY21 through about 86 million in global awards, primarily to public international organizations or PIOs, primarily United Nations organizations. The FY21 performance evaluation that included that objective 5, it included assessment of that objective 5, and the team determined with BHA that there was room for more learning on that. So my colleague Erin will share a link to the brief that covers that objective 5 performance evaluation assessment in the comments. So you can also take a look at that as the study really complements and builds on those findings. And this topic is still timely as global efforts continue to improve pandemic preparedness, from ongoing pandemic treaty or pandemic accord negotiations to a new US government global health security strategy in this past year. And as WHO frameworks have been revised with COVID learning, that includes May 2024 International Health Regulation amendments, the 2023 Health Emergency Preparedness Response and Resilience, or HEPR framework as well, which we'll come back to and use as framing for this study. And just earlier today, ALNAP just launched a COVID-19 evaluation synthesis. Next. With BHA, we refined the research questions to 3 overall questions. Question 1 is what pandemic preparedness capacities were strengthened in the humanitarian architecture across levels and what gaps remain. And that includes also looking at the ways that capacities were institutionalized or not. Question 2, how can capacities be built and sustained in fragile, conflict-affected, and vulnerable settings? So FCVs, or we might just refer to this as conflict settings in the presentation. And question 3, what promising practices emerged from this BHA support? And these findings in the report are framed around the 5 C's of WHO's HEPR framework, and those are shown in the graphic on the slide: collaborative surveillance, access to countermeasures, emergency coordination, community protection, and safe and scalable care. And as we gathered evidence for this study, we included evidence of capacities that had been built directly or also indirectly supported through BHA support. Next. We identified 4 main levels for which we would gather evidence, identifying evidence in cases or examples where capacities were built across multiple levels of the system, so vertically, and then comparing cases within each level as well. The main data sources were 62 remote and in-person key informant interviews across levels and stakeholder groups of the BHA funding, qualitative data from case studies in Syria, South Sudan, and Honduras, and 129 health worker surveys in those case study countries, and integrating relevant award reports and literature. And also noting that the report that supports this webinar defines some of the key terms we've used in this study, or shorthand terms, such as using preparedness instead of readiness only. So you can find that in the report. Next slide. Now, going into evaluation findings, I'll present a summary of the key capacities and gaps identified by each study level. Starting with global and regional capacities. In all 5 Cs from the HEPR competencies were enhanced at this level. Not shown on this slide, but in table 1 of the report on this study, you can see an overview table giving select activity examples for each HEPR competency and level. And Erin can post that link again in the comments if she hasn't already. So thanks, Erin. And then you can follow along. For the coordination competency, this included support to enhance sector coordination, tools, technical support, and information management. This was supported via global health cluster strengthening, improved multi-sectoral cluster coordination, surge and joint assessment mechanisms set up across levels, and global open courses. Some of these courses, actually many of these courses, included surveillance capacities, which contributes then to the HEPR collaborative surveillance competency. These supports were from the global level on down across levels, but long-term funding for the global health cluster and for coordination mechanisms across national and subnational levels continues to be a challenge, as is securing agreements for humanitarian data sharing, which were key to identifying needs during pandemic restrictions. In terms of global training resources, a gap we identified is the need to assess effectiveness of online trainings. Next. Continuing on at this level, according to KIIs, the HERAM's development and expansion from BHA's COVID-19 investment will allow the platform to operate on a significantly smaller budget going forward. This system provides detailed health facility capacity information, which could potentially be used for pandemic preparedness and response, though the evaluation was not able to gather evidence to assess its use for an infectious disease response at the time of the study. Greater coherence of risk communication and community engagement, RCCE, or community engagement accountability, CEA strategies among stakeholders was a key contribution to the HEPR competency of community protection, including BHA's funding of the evaluation of the RCCE collective service. We highlight in the report the multi-level or system-wide promising practice or promising example of the International Federation of Red Cross and Red Crescent Societies, IFRC's new CEA strategy that has been providing capabilities now since the pandemic time at global, regional, and national society levels. And we captured evidence across these levels and then focused in on the Honduran Red Cross that BHA funded work through our case study. While BHA directly funding the humanitarian buffer, the challenges for which have been well documented in various external reports, it has provided technical support and has coordinated with the USAID Bureau for Global Health to coordinate with Gavi and other actors to document learning and to improve future humanitarian vaccine responses. Finally, BHA supported advancing the WHO Health Emergencies Program, or WHE, and in particular their operational role, such as in medical supply chain, and specifically later. But overall, for the global level, given the complexities of confronting pandemics in humanitarian settings, the evaluation found that BHA's support for the enhancement of the WHO health emergency operational capacity was a key strategic investment into the WHE. Next slide, thanks. Moving on to the level of BHA and USG coherence, our evaluation revealed significant progress in BHA and US government or USG coordination mechanisms for pandemic preparedness and response. On the USG side, generally, there's the establishment of a new interagency coordination structure led by the National Security Council, which proved effective during the MPOX response. Additionally, new bodies like the White House Office of Pandemic Preparedness and Response Policy and the State Department Bureau of Global Health Security have been created in recent years, as well as the USAID Bureau for Global Health Outbreak Response Team, which was born from the Ebola epidemic learning. BHA has made strides in coordination, particularly through direct and ongoing collaboration with the CDC, ensuring better program alignment. and the revised USAID Outbreak Response Framework has also proven valuable. And one example of how this coherence extends to the project level, we heard from a health partner in Sudan who had received BHA funds to keep primary health services up and running, that they were operating alongside and utilizing this diagnostic and laboratory support of CDC, who was setting up those capabilities in the same area. However, we've identified a key gap, the need for more operational planning and interagency response framework simulation exercises with BHA and with BHA's USG-related stakeholders or partners. And these exercises are critical for testing and refining roles and mechanisms before we face the next health crisis. Next. In building on the coordination efforts, BHA's strategic positioning has been noteworthy. BHA's decision to address secondary effects of the pandemic and the FY21 response proved highly effective, and that included a focus on protection and gender-based violence, food security, community engagement to address mistrust. And the evaluation identified a promising strategy in BHA's use of fixed amount awards, or FAAs, for building global pandemic capacities. And this approach offers both flexibility and built-in accountability, which are crucial in rapidly evolving crisis situations. Though the FAA mechanism in the future could be improved, and we've listed here some suggestions for ensuring clear milestones. Next. At the country and implementing partner level, the evaluation revealed significant improvements in local government coordination and an IP or implementing partner multi-sectoral response capacities. COVID-19 funding enhanced coordination between IPs and governments in humanitarian settings, laying groundwork for future outbreak and all hazard responses. A key success has been the sustained partnerships with ministries of health, which have facilitated ongoing availability of essential health and nutrition services. Local governments were strengthened in the areas of surveillance, all-shock emergency planning, as you can see from the quote on the slide from Mozambique, pre-positioning supplies, referrals for protection systems, and support of direct service provision to maintain basic health, nutrition, water, sanitation, and hygiene, or WASH, and food and cash assistance. While the ability to effectively coordinate with governments and ministries of health may vary by country, there are multiple examples of collaboration that may be sustained. The Nigerian Centers for Disease Control federal agency was pivotal to the response in the emergency regions of northern Nigeria, coordinating closely with WHO and IPs according to the evidence we gathered from interviews and reports. As an example of multi-sectoral responses, in Syria, the simultaneous cholera COVID-19 response led IPs to collaborate with schools and the education sector to provide awareness and services. Next. And locally recruited coordinators and managers, a common feature of BHA-supported IP projects, also played a key role in the coherence and continuity of health and other basic services for program management and ensuring adequately adapted programs to gain community trust during the pandemic. IP programs gained crucial capacities in IPC, RCCE, and beyond, such as training local organizations and community leaders in rumor tracking and social listening for health promotion. Also, trainings occurred in response operations capacity, such as through the READY initiative or supply chain systems through JSI, all of which are applicable far beyond COVID-19. BHA has supported country-level WHO personnel in the country business model also for priority humanitarian settings, which is another key way that BHA has supported WHO's operational role. Again, noting the funding challenges with key health, nutrition, and mental health services reinvigorated during the COVID-19 response, and we should say WASH and health facilities and communities. The funding was able to reach new populations or restart and reinvigorate many services, but then the rapid decline of services with lower budgets has now occurred, while much of the need in these protracted emergency settings has remained. Next. Moving on to the final level, community level. First, at the health worker and facility level, health workers reported improved capacity to protect themselves, patients, their health facilities, and communities from infection. And the vast majority of primary level health workers surveyed across Syria, South Sudan, and Honduras felt mostly confident to face a future emerging health threat. And that's an amazing achievement terms of their perception of self-efficacy to do so. 80% of health workers felt supported by their facilities or organizations for future outbreaks, and most already having faced concurrent or subsequent outbreaks since COVID-19. As shown in the slide chart, IPC guidelines were the most commonly institutionalized practice from COVID-19 at that facility level, according to the health workers. And we should say the health worker survey data collection occurred just this last March or April. Not shown on the slide, but discussed in the report, the most salient COVID-19 training topics recalled a year or more post-training by at least 3/4 of the surveyed health workers included proper use of personal protective equipment, PPE, knowledge of COVID-19 transmission symptoms, and how to implement IPC procedures in their health facilities with capacities around setting up triage spaces and a lot of creativity in trying to adapt health center spaces to do so, and isolation spaces, with wash partners setting up better hand washing and sanitation systems within health centers, all really key features that we documented. Yet the barriers or gaps in health worker readiness for future outbreaks were staff shortages, no ongoing training systems related to future outbreaks or pandemics, lack of consistent pay, and medical supply or PPE shortages. And overall for communities, the evaluation found some communities are sustaining various health promotion and health-seeking behaviors resulting from the IP interventions. Examples reported by IPs and communities include sustained hand washing practices, improved communication and mechanisms that bridged communities and local health centers, and perceptions that these activities reduce transmission of COVID-19 and other diseases. Next. We use the case study countries of Syria, South Sudan, and Honduras, representing very different settings or insecurity settings to distill learning for these contexts. In conflict settings where state actors may be weak, absent, or even hostile, PIOs or UN in particular may play a crucial role in capacity strengthening of local government representatives and where possible, and in utilizing national organizations to implement. We found it's essential not to overlook local governments, supporting them to take the lead in pandemic coordination or guideline dissemination, even in these settings. International NGO partners are also crucial in these settings, filling multi-sectoral services gaps, and sometimes through fixed funding, being able to provide multi-sectoral funding longer than the typical emergency cycle. And to build the health emergency preparedness and response, or HEPR capacities in conflict areas, we suggest approaches that focus on enhancing and building the frontline human resources. So the health workers, the community health workers in particular, linked to primary health centers or mobile clinics was a common feature and a common strategy during the pandemic and was very effective. And they need ongoing support. And continuing to strengthen local systems and infrastructure, that local governance where possible, and then continuing to foster the community engagement that's so necessary for any response. And these elements are critical for establishing resilient health systems capable of responding to pandemics, even amidst conflict and other shocks. The recent USAID Big Picture Reflection Report on COVID-19 included 8 lessons, one of which was that health system resilience is central to most responses to crises and shocks, and not just public health emergencies. Next. Finally, we wanted to share a snapshot of a promising practice focused on health supply chain and logistics. During the pandemic, WFP's logistics and transportation capacity was crucial for quickly moving humanitarian personnel and supplies, and BHA provided support for that in key regions. Though technical expertise was needed to procure and safely manage various pharmaceuticals and medical commodities, or PMC. So WHO's Health Emergencies Program, WHE, helped fill that crucial gap, providing guidance, information, and coordination for supplies procurement in key humanitarian contexts during the pandemic. In our report, we document some examples of this in practice, such as through WHO pooled procurement and pre-positioning of PMC in coordination with WFP and other humanitarian actors in country, South Sudan being an example. But our study team has been left with the question of, will this really key area for pandemic preparedness continue to be improved and readied for the next pandemic now? So moving on now to conclusions and recommendations. and hope you're starting to percolate your comments and your questions and putting those in the chat. So in summary, global and regional preparedness capacities were built for cluster coordination, surge and information mechanisms, coherence of RCCE strategies among stakeholders, and in advancing the WHO health emergency program's operational role, such as in health supply chain and logistics. For BHA and USG coherence, great progress has been made within BHA and across relevant USG offices to improve and institutionalize coordination mechanisms for future outbreak response. Important capacities at country and IP level included improved local government coordination and capacity strengthening, as well as building IP adaptive and operational capacities among their staff and systems. At the community level, the COVID-19 response left a legacy of improved IPC among frontline health facilities, which need to be maintained for future pandemics. And we learned that key strategies for pandemic capacities in conflict settings require a nuanced approach, integrating governments when they are capable and working with PIOs and local partners in settings where state actors are weak, absent, or hostile. Engaging and building trust with local stakeholders and investing in local staffing are also key to sustaining results in these fragile and protracted contexts. Overall, building lasting capacities in humanitarian settings requires persistent investment, coordination efforts across sectors and levels, and unwavering commitment by humanitarian donors and actors. Next. Finally, we'll present recommendations first for USA, BHA, and then for the partners. BHA with Bureau for Global Health and CDC should continue to collaborate on a USG-wide strategic plan for capacity building of the humanitarian architecture for future pandemics, which may involve WHE and others. This plan should clearly outline which capacities each USG funding stream will prioritize and any potential areas for collaboration and advocacy with other donors. This includes outlining with WHE and others the potential impact of the lack of funding, not only on humanitarian architecture, but on the global health security agenda. BHA's global award should consider better utilizing the FAA mechanism as noted and longer time needed for achieving clear milestones for pandemic preparedness. Second, the pandemic capacity building strategy from the above recommendation should be integrated into and monitored across BHA's ongoing humanitarian health awards, even at the country level. Maintaining primary health services and a well-equipped frontline workforce in infection prevention and control and other topics are critical for outbreak readiness in conflict and fragile contexts. 3, BHA should advocate for flexibility to support local government capacity building for strengthened multi-sector responses, where appropriate, partners. Health clusters can be another vehicle for supporting government engagement and capacity for response leadership. 4, BHA should consider collaborating with initiatives that invest in training institutions in key protracted emergency contexts to support the health workforce. And 5, recognizing that pandemics demand standardized and scalable capacities built quickly and effectively, BHA should ensure awards include impact evaluations of e-learning programs to better guide the evolution of this powerful tool, and future awards should include real-time evaluation of e-learning effectiveness. Next. And now recommendations for partners. 6, partners should continue fostering COVID-19 era mechanisms for multi-sectoral response coordination. This includes support for subnational coordination with local actors and government entities. Partners should maintain the RCCE or CEA skills in emergency contexts that were at the forefront of the COVID-19 responses, ensuring their integration into ongoing response efforts. And finally, recommendation 8, partners should develop sustainable mechanisms for continuous training and refresher courses to help maintain the many important COVID-19 capacities that have been built, investing in systems within their organization's efforts. This includes outbreak response management and operations for national staff. And it includes continuing to strengthen IPC skills and practices for frontline stakeholders and systems. Please check out the additional performance evaluation reports in brief format and the annex document with more background and results from the FY21 COVID supplemental performance evaluation. We also have the annex with more in-depth of our case study countries that we mentioned today. And if you were not able to make it to yesterday's webinar on Thematic 2, we have that link here as well. And through my current dissertation work through Johns Hopkins, I'll also be releasing additional analyses and papers focused on pandemic capacities built among frontline health workers in humanitarian context during COVID-19. And that focuses on the community and primary healthcare level. So if you are particularly interested in that theme, please feel free to send me an email and be in touch. And my email is on this slide. And now I want to hand it over to Dr. Nancy Mock before we head into discussion to give any additional remarks or provide any emphasis on some of our findings, and then open it up for Q&A. Over to you, Dr. Mock.
Great. Well, thank you, Marietta. That was very comprehensive, so comprehensive in so much detail. What I would like to do is bring us up to the 30,000 foot level for a few minutes before we discuss Q&A. One is that in terms of BHA's mandate and and the funding that was allowed for this preparedness activity, it was really very modest. So when you look at all these results, think about the fact that only 6%, it was, I think, in the area of 78 million was, was devoted to this area of work. So keep in mind that this was modest in comparison to other work, where in fact probably quite a bit of readiness, as we explored today, was developed, but not necessarily specifically targeted. And the other thing is, I think another big picture issue is the major changes in the ecology of epidemic management, which again, Marietta alluded to. So much has happened. It's so different. And if I could say, being older, I was around the H5N1 scare happened around the time of the first version of the IHR. And, we threw a bunch of money at preparedness, lots of trainings. And after that, nothing much happened. And then, of course, came, SARS and Ebola and then COVID. And, we've actually, the ecology has really changed and evolved quite a bit, both internal to U.S. government and also external to other international players. So the ecology is both changed a lot, but it's also evolving very quickly. And so one of the things I think for BHA and others is to keep tabs of that and be connected at that in the right places. And so that to me is a challenge, but a good one. Because we have more resources available for dealing with epidemics and health threats. So I think it opens great opportunity for us that we shouldn't lose sight of. A comment also about the work that BHA did during this response. I mean, you can imagine that quite a lot of resources were flowing in to BHA. And BHA had to manage that. And the Thematic yesterday talked about that and what the challenges that were. But some of the things that were particularly strategic that BHA did was one, again, this operational capacity of WHO, which doesn't define itself as an operational agency, but in fact, in the case of in the bigger picture of the humanitarian architecture to deal with health threats, it has an important operational role to play. And this again, it does require sustained investment. Right now, from what we could tell, there was not great ownership by WHO and support of WHE, and its funding is definitely highly vulnerable. So we're, thinking, yeah, BHA did a great thing in identifying and focusing on this. Also, in terms of the focus on humanitarian populations, it's bread and butter in normal times. This also was a challenge to ensure that humanitarian populations were able to be, given resources to manage this epidemic, and in picking out some neglected areas, community engagement and accountability, particularly, we felt was an area that is absolutely essential to managing any health threat. And this was one where substantial progress was made, actually. And in distinguishing RCCE, the RCCE is usually RCC and not E, and then not RC and not CE. So the fact that these areas were really looked at and focused on, and the tremendous work that IFRC did was quite important. I would say also the perishable data issue. One of the things, again, yesterday it came up, is that, when you deal with emergencies, and especially with the movement of people and the system and so forth, data goes away. I mean, during our interviews, many times people said, well, we'd ask a question about what happened, and, well, you know what, I can't remember. No. So this notion of, dealing with perishable data by having systems in place to capture information as emergencies are evolving through real-time evaluation is important, as well as in this case where capacities are building capacities are an objective, looking at establishing monitoring systems to make sure that they are in fact maintained. So that would be I guess a final comment on my part. So with that, we're looking for questions from the audience.
Yeah, please feel free if you have a question, a half question, and a comment, anything that really resonated with you, we would love to hear. We don't have the ability to unmute you in this webinar format, so please do type it in the Q&A or the comment function. And while we're waiting for those, Aaron Franklin, also a key member of this study team, putting you on the spot here, is there anything that comes to mind or that really stuck out to you in doing this research that maybe we missed, or that you would want to give examples of?
Sure. Yeah, absolutely. So I would just highlight, and we've kind of gone over this in the presentation, but I think one thing that I noticed throughout this evaluation is that the developments and frameworks and programs that served as preparedness, that to make people at the country level and the global level prepared for the COVID pandemic actually came out of the Ebola crisis. And so I think just taking that view of learning from the Ebola outbreaks really helped with building up for the next crisis, which was the COVID crisis. And so I think, it just really highlights the depth of the need to continue sustaining investments into these capacities that were built out of all of this funding, and so that we can be prepared for the next pandemic. So,
thanks, Erin. Any comments? It's great to see a good mix of folks online today, and I know some have already had to leave, but definitely representing a lot of the key partners that within BHA, and also implementing partners who I know we've been in touch with to try to bring together for this study.
And Marietta, it would be great if we have any questions or even comments from our participants. We still have 20 odd participants online.
Yeah, definitely.
We'd love to hear from you. Maybe everybody's got pandemic fatigue.
I do see we have a hand up in the chat. If you could potentially type the question, we are unfortunately unable to unmute you. Oh, there you go.
Okay, one big challenge mentioned was the limited mandate of BHA with regards to pandemic preparedness. Having a more comprehensive USG framework to address some of those core capacity strengthening in a consistent manner would be key. Absolutely, Julie. That is such a like an important comment and something we think, again, this ecology of pandemic management is growing and the resources are growing, and really connecting to those and being able to facilitate sometimes as opposed to implement, facilitate how resources are better utilized is really important. So thank you for that comment.
Yeah, definitely. And I think this resonates with our first recommendation to BHA on developing that strategy with CDC, with Bureau of Global Health, so that the roles and priorities of what's being covered across USG is more clear. And then, yeah, BHA is from the field level or country level on up, a great facilitator often of bringing different funding streams to the table and really being able to look at that. But another piece just from another key conclusion from our performance evaluation, which of course was multi-sectoral and not just on this topic though, was a very clear desire from humanitarian partners, or even expectation that's come out of the COVID pandemic, for trying to build some lasting response mechanisms, and trying to build that preparedness, and wanting more sustainability of results and inputs, even for humanitarian programming, which maybe has not been as much the mentality or the culture of that kind of programming in the past. And so that's something that we have also documented in that report. And I think also another thing that comes to mind for around mandate is there is a new humanitarian local capacity strengthening strategy in humanitarian settings that USAID has just released within the last few months. And this is a common theme also in this report and in this whole evaluation series too, of not forgetting those local government, in particular, those local government partners, and the capacity strengthening that's really already happening among those partners. And then, of course, with MOHs in particular, happening with COVID. So partners are asking BHA also for some more guidance around that. And there is that new strategy I just referred to that does, recognize local government or national and subnational government as key local actors as a part of the localization strategy. So, in terms of how humanitarian partners see their role with capacity strengthening with local government, I think will be an interesting area that continues forward.
I think, Marietta, one of the other things that we, have learned, and of course it's no surprise, right, is the large global constraint we have with respect to getting access to pharmaceutical and medical supplies to humanitarian populations and low income, populations. That continues to be a major problem, and I think there are a lot of new innovative approaches, such as more local production and such. But that was an area where we saw that there is really a long way to go. I think partners did innovative things to ensure that supplies were available, but in terms of some of the big things like vaccines, remains a big constraint, and something not for necessarily BHA just as a facilitator, but it's a major constraint to preparedness and ready.
Just recognizing here that participants from Uganda that have conducted BHA field research in the past, so thanks for that comment. Okay, anything else? Any other of our colleagues wish to say anything, or from BHA?
Nothing else for me. Just thanks to you all for joining us.
Yes, thanks, everyone.
For me, thanks, everybody.
Okay.
Yeah, thanks everyone.
Okay, well, with that then, feel free to be in touch if a question or comment comes to mind. But we will end the webinar there and really appreciate your participation and being a part of this discussion and learning with us. Have a great day.